Welcome to my channel. Today we'll discuss the gross anatomy of the thyroid gland. Thyroid gland is presented or located at the level of the fifth cervical vertebrae, as between the fifth cervical vertebrae and the first thoracic vertebrae, that is C5 to T1. It consists of majorly two lobes, the right and the left lobes of the thyroid gland. These lobes are connected at the center by a narrow isthmus. And these lobes are pear-shaped, and the apex are actually facing upward towards the lamina of the thyroid cartilage. The isthmus of the thyroid, that is the central portion that is linking the two lobes, the right and the left lobe, extends across the midline in front of the second, third, and fourth tracheal ring, as well as the thyroid cartilage upward. In a cross section, the thyroid gland is seen to be a vascular organ surrounded by a sheath derived from the pretracheal layer of the deep fascia. This pretracheal layer of the deep fascia actually keeps the thyroid gland in place. More laterally, the thyroid glands are being related by the vagus nerve, the common carotid artery, as well as the internal jugular veins. These three major structures are also enwrapped by part of the pretracheal layer of the deep fascia, but for specificity, this layer is called the carotid sheath. Now, the posterior aspect of the thyroid gland is supported by the trachea, of course, the tracheal ring. Now, the anterior aspect of the thyroid gland is covered by the muscles of the anterior triangle of the neck, the sternothyroid muscle, the stenohyoid muscle, the superior belly of the omohyoid muscles are all in the anterior aspect of the thyroid gland. So if you retract these muscles, you find the thyroid gland in the anterior aspect of the neck. Also, the relations of the thyroid gland, as I have just mentioned, the anterolateral aspect involve the stenohyoid muscle, the superior belly of the omohyoid, the sternothyroid, as well as the anterior border of the sternocleidomastoid muscle. Retracting these muscles exposes the anterior surface of the thyroid gland. Okay. The thyroid gland on the posterior aspect are actually related to the four major structures that are separated up and down, or that are referred to as superior and then the inferior parathyroid gland based on their location. So those in the anterior pole, that's posteriorly, are the superior parathyroid gland, and those in the thyroid on the lower or the inferior pole of the thyroid glands or the lobes are referred to as the inferior parathyroid glands. Recall, the lateral or the left and the right poles also carries their superior right, superior left parathyroid gland, inferior right, inferior left parathyroid gland, posterior. Another important information on the posterior aspect of the thyroid gland is the anastomosis between the superior and then the inferior thyroid artery. An important information here, we talked about the enwrapment or the enshrinement of the thyroid gland. Okay, so there is what is called retrosternal thyroid or goiter. Now recall, we have said that the thyroid, the pretracheal deep fascia of the thyroid of the neck keeps the thyroid gland in position. Now the attachment of the sternothyroid muscles to the thyroid cartilage effectively binds down the thyroid gland to the larynx this time. Now also limits the upward expansion of the gland. However, the downward expansion has no limitation. So this shows that if any pathology enlargement of thyroid gland occurs, there is a possibility of a downward extension behind the sternum. So this scenario is referred to as retrosternal goiter, because there is no stoppage, there is no limit on the inferior aspect of the thyroid, whereas if you look at the superior aspect of it, the pretracheal layer of the deep fascia keeps it in check and wraps it. Another important information here is that any abnormal enlargement of the thyroid gland can compress the trachea and cause dangerous deafening. It can also cause severe venous compression. Let's move. So let's look at the blood supply. The blood supply of the thyroid gland are majorly from either superior thyroid artery or inferior thyroid artery. Sometimes there is a third supply that comes from the thyroid ima. The third one is called the thyroid ima. Let's look at a more exposed diagram. Okay, look at it. There are the superior thyroid artery, the inferior thyroid artery, and sometimes the thyroid ima. Now, the superior thyroid artery, you can see, okay, it's a branch of the external carotid artery, which also descends to the upper pole of the lower or of the lobe, also being followed by the external laryngeal nerve. Okay, left and right. Left and right. So another one is the inferior. Let's look at okay. There's also inferior thyroid artery. Look at the inferior thyroid artery. Inferior thyroid artery. This one is actually a branch of the thyrocervical trunk. Thyrocervical trunk. Okay. Now, sometimes I also mention that thyroid ima exists. If thyroid ima exists, which is basically in 10% of humans, the thyroid ima takes its origin from the brachiocephalic trunk, sometimes from the arc of aorta. Okay. Now, the veins follows to the superior thyroid vein that drains into internal jugular vein. This time there is middle thyroid vein that drains into internal jugular, whereas the inferior thyroid vein, okay, drains from both sides, or anastomosis from both sides, one another, and then descends in front of the trachea. You can see this in front of the trachea, and then empties into the left brachiocephalic vein in the thorax. That is the inferior thyroid vein, while the superior and the middle thyroid vein drains into internal jugular vein. Of course, remember, internal jugular vein follows the internal jugular artery that was part of the carotid sheath on the lateral aspect of the thyroid gland that we mentioned before now. Okay. Next, the lymphatic vessels of the thyroid gland. The lymphatic vessels of the thyroid gland communicate with capsular network of the lymphatic vessels. You can see the yellow patches. Okay, from this network, the vessels pass initially to prelaryngeal, peritracheal, and then the paratracheal lymph node, which drains in turn to the superior and then inferior deep cervical node inferior to the thyroid gland. Okay, the lesion, assuming there is lesion of the laryngeal nerve. Remember, the laryngeal nerve, the muscles of the larynx are innervated by the recurrent laryngeal nerve. So, with the exception of the cricothyroid muscles, so the supply to these muscles or to the cricothyroid is from the external laryngeal nerve, whereas every other muscles of the larynx are being supplied by the recurrent laryngeal nerve. So both these nerves are vulnerable during operation on the thyroid gland because of the close relationship between the nerves, even the artery. So it should be between the nerves and the artery. So during the operation, it should be closely monitored. Because if anything happens to it, assuming there is the superior thyroid, the recurrent laryngeal vessel is severe because of its closeness to the superior thyroid gland, it will lead to lack of supply to the muscles of the cricothyroid muscle, which it supplies. So damage to this external laryngeal nerve results in an inability to tense the focal fold, and this result also results in hoarseness of voice. So during operation, the external laryngeal nerve should be watched out for, because it relates closely to the vascular vessel, that is the superior thyroid artery, and then it should be taken care of. It should be avoided by all means, not to be severed. Okay. Now, the terminal part or branches of the inferior thyroid artery on each side are related to the recurrent laryngeal nerve. You can see from this. Okay. Closely related. So care should be taken. Now, let's look at the congenital anomalies of the thyroid gland. Congenital anomalies. One of these is agenesis, absence or failure of development of thyroid gland. During development, there could be incomplete descent of thyroid gland. There is development with thyroid gland refuse to descend based on maybe could be arrested during development. So, laryngeal thyroid or lingual thyroid is the most common form of incomplete descent of the tissue of thyroid. So instead of thyroid going to the anterior aspect of the neck, it could be stopped in the tongue, could be stopped immediately after the tongue, could be stuck at the buccal area, could be stopped anywhere. So based on the location of its presence, because it has not gotten to the original location. It could be called buccal tissue of thyroid. It could be called lingual thyroid. So persistent thyroidal duct conditions related to the persistence of the thyroglossal duct. Usually appears in children or in childhood, and then in adolescence or in young adults. Look at another congenital situation is called a Thyroglossal cyst. This is occasionally occurred when a thyroglossal cyst rupture spontaneously, producing a sinus. Usually this is a result of an infection of the cyst. All remnants of the thyroglossal duct should be removed during any surgical procedure. And let's look at another one here, the thyroglossal cyst. These cysts, which are remnants of the thyroglossal duct, may be anywhere along the migration pathway of the thyroid gland. They are commonly found behind the arch of the hyoid bone. An important diagnostic characteristic is their midline location. Okay. I don't want this video to be too long. Let's see if I can wrap up. There could also be aberrant thyroid tissue. This may be found anywhere along the path of descent